So we're going to talk about ocular ultrasound. This is actually this is like the second generation of ocular ultrasound. Luckily, it's improved significantly since then. We're going to talk about why do we even bother doing it? How do we avoid missing something on the ultrasound? How do we get a complete study? And what else is there in there that we should be looking for? I use ocular ultrasound when I want to see this on my patients, but all I get is this. And even that sometimes is a good day. I like it because it makes this a very simple question. It basically is which circle has something in it and which circle does not. And the one on the right looks pretty suspicious. The patient complaints that I use it for the most are if patients have flashes, if they have vision loss, if they have floaters, or if they have curtain vision loss. We'll go through the anatomy very briefly here. So we're ultrasounding through the eyelids, so we'll see that on the top of the screen. Then next we'll see the anterior chamber. Ophthalmology's ultrasounds are set at fairly high frequencies, so they can see this anterior chamber quite well on some of their exams. But for us, it's really just part of the eye that we see while we're looking at the main event, which is back here in the posterior chamber. You may see a little bit of the lens up here. If they have a native lens, it's curvilinear. People with lens replacements, they're flat. And then in this back portion of the eye, the posterior chamber, there's this glob of gel that's called vitreous, and then there's fluid around it as well. As we scan through, we'll often see the optic nerve in sheath, which is kind of showing up as this hypoechoic line in the back. And then the portion of the eye that we don't really see as distinct parts because they're not sonographically distinguishable are the sclera, which is quite bright on ultrasound, the choroid, which is just a layer of blood supply for the retina, and then the retina itself, which is also hyperechoic, but we don't really see it as a distinct entity from the sclera in a normal eye. A lot of the pathology that we're looking for is caused by vitreal problems, and that's because when our eyeballs are formed, they're formed around this glob of gel called the vitreous. But as we get older, this glob of gel dries up and becomes a raisin. As that raisin dries up, you might actually get some symptoms from it. People can actually have some floaters. Sometimes when we're ultrasounding eyeballs, you can actually see that vitreous floating around in there as this little kind of glob of gel that sort of bounces around and doesn't usually cause any problems. But in a small number of people, as that gel dries up, some of the retina stays attached to it and it starts to pull on the edge of the retina. This is when patients have flashes because the retinal nerves can't actually transmit pain. Instead, all they can do is transmit light, and so the flashes are basically the retina's way of saying, ow, stop that. Sometimes when you have one of these little areas of traction, it tears the retina, and people have a lot of floaters very acutely, and that's because they're having some blood coming from the choroid layer and entering into the eye through the edge of the retina. You'll sometimes see them moving around. This is a patient with vitreous detachment and also a bunch of kind of debris from some blood in their eye as well. Retinal tears are often very small when they start from these vitreal detachments, and they're just kind of these little tiny flaps that ophthalmology likes to know about and repair at some point in time, and that's usually over the setting of weeks. If we can identify them when they're these small settings, then we can save basically all of this patient's vision, except for maybe this very small area of peripheral vision, which isn't going to even be noticeable for them in most situations. However, if we miss this retinal tear, what can happen is it will turn into a detachment if the fluid from the eyeball starts to sneak in behind that tear and then strip the retina off of its blood supply of the choroid and make it bigger and bigger. So this is this kind of hydrodissection of the retina off of the choroid that causes these larger tears, which is what we're looking for in our ultrasound. When you see anything that's a symptomatic retinal detachment and ophthalmology is consulted, they usually repair these usually in the timeline of hours to weeks. So not all of these are emergencies that will go to the OR the same day, but most of them will be repaired within the next couple of weeks, depending on the patient's story. So hopefully I've convinced you that vision is a good thing and that this ultrasound is going to be useful for us. So let's talk about how to actually do it. So we're going to talk about setup, and then we're going to talk about probe movements. When you're setting it up, you want to pick a machine that has ocular settings because you want it to be low energy, not only because the FDA requires it, but because we don't want to inadvertently heat up the eyeball. You want a high frequency probe so you can see things well, and because the eyeball is very superficial, and it has a small footprint so you can fit into that orbital edge. So that's going to be the small probe that we have on the S series ultrasound machines. You want it to be able to export to QPath, so although the IV machines that we have in the ER would work great for this, they don't export to QPath, so we are using this S series, which is a little generation older than that, but still quite adequate for ocular ultrasound. In order to set up the patient, we want to make sure that we're protecting their eye, but still using something that can break that air barrier between the probe and the eyelid itself. Typically, we start with using a plastic film and lots of gel. The challenge with this is that sometimes we get air trapped under that plastic film, so people use a lot of other things instead. If you have access to it, then I highly recommend just some lubricating ointment, which is basically just really thick liquid or really thick water, which is approved for eyes, and it's what we use in patients who have Bell's palsy, who can't close their eyes at night. They use them to keep their eye lubricated. Surgilube is mostly eye-friendly materials, but our particular Surgilube packets have chlorhexidine in them. So does our big bottle of gel, actually, so using this isn't any better. These small packets are usable and is probably what I'd still use in most patient cases, but please try to keep it out of the patient's eyes. And I usually try to wash it off with a wet washcloth afterwards to try to minimize how much they get into their eyes. There's a couple of papers about emergency medicine physicians using petroleum jelly because this is a fairly safe material for eyes. However, our manufacturer tells us that it's not a particularly safe material for the ultrasound probes themselves. So if you are going to use petroleum jelly on the eye, what I'd recommend is that you put a very thin layer of ultrasound gel on the probe itself. So basically thin, tiny little layer, and then put Tegaderm over the probe. And then you can just go ahead and use that on petroleum jelly on the patient's eye. If you're going to be using the plastic film on the patient's face, then you want to make sure that you apply it similar to a screen protector on a phone where you're getting all those air bubbles out of it as you're applying it and pushing sort of all to one direction, one side. I usually start at the medial canthus because I find this the hardest place to get that Tegaderm to really get all the air bubbles out of. So I place it into that medial canthus and then kind of slowly push all the air out as I go laterally and take those little paper strips off of the edges. If you don't do this, you'll end up with a picture like this where you have a big air artifact here and a big air artifact over on this side, and you really can't see about more than a third of the posterior portion of the eye. If you have a film layer on the patient's face, then you can go ahead and put a big, huge blob of gel and basically fill up their entire orbital ridge with this ultrasound gel. If you are only using gel and not a plastic film, then just use a teeny tiny bit of gel on the probe itself, basically just enough to get it wet. And then you can do basically the same technique. Next thing you want to do is anchor your hand on the patient's face, either on the bridge of their nose while you're holding that probe or on their forehead. And then the other thing that's going to be helpful is to support the ultrasound machine cord. You'll find that using these small movements that we use on eyes, especially in the eyeball, which patients don't like a lot of pressure on, it helps to have the weight of that cord off of the probe itself. So I usually put it over my shoulder or on my neck if I'm wearing a coat, or hang it up on the ultrasound machine, or have even an assistant hold it for you. Then you have to adjust the machine settings. On our S series, remember to hit New Exam if you can, because otherwise it might put it on a different date. Sometimes it forgets that the new exam is starting today and thinks that it was started several days ago. The next thing you want to do is make sure that you're on ophthalmology settings. And lastly, you want to optimize the patient image. For whatever reason, Sonosight's settings for eyes are not actually consistent with the depth of most people's eyeballs. And so make sure you increase the depth a little bit past the point of where Sonosight has it, because it's usually like kind of right at the back of the eye, and we want to be a little deeper than that. Finally, you're allowed to scan. So the whole point of this ultrasound is to get a good sagittal view and a good transverse view in two planes. So you want to make sure that you visualize all of the inside of the eye in these two different planes. We're going to talk about how to do that. So one thing that you can attempt to do is you can have the patient try to scan themselves. So if you have, especially if you have plastic film on one side, you can have an assistant or yourself move your finger up and down while you just hold the probe steady and watch them scan their own eyeball. Rotate the direction and do it up and down. Most patients can't follow instructions that well, so my experience has been that I usually end up scanning them anyways. So in order to do this, you want to hold that probe in either view. You can start either sagittal or transverse, and then scan, if you're in the horizontal view, scan up and down all the way through the entire back of the eye. Then rotate your probe and scan all the way back in the other direction. For QPath, for credit for the scan, you want to sweep all the way through, so you basically need at least 2 clips and 1 freeze frame. You want to have 1 clip all the way through sagittal and 1 clip all the way through the coronal view, so both directions. And then some extra view, whether that be a clip or a freeze frame, and we'll talk about those in a little bit. If you are trying to be more complete, then I'd actually recommend 4 clips, with each of them being just a quadrant of the eye. So start at the optic. So if you're starting with the probe up and down, you start with the optic nerve, and then you sweep, pointing the probe over towards the patient's temporal area, and then start the next clip back at the optic nerve and sweep all the way to the nasal area. Rotate the probe, start at the optic nerve, sweep all the way through the superior area of the eye, and then start back at the optic nerve for your last clip and sweep all the way through the inferior portion of the eye, in which case you still need an extra view, but you have 4 clips and you know that you've seen every portion of the eye, even if the patient moved their eye during the exam. I'm going to talk a little bit about some retinal detachment myths, and then we'll talk about some other things that you can do to optimize your scan. So there's a couple retinal detachment myths that drive me a little bit crazy, so here's my chance to make sure that you do not fall victim to these myths. Retinal detachments are often easy to see, and we're actually quite good at finding retinal detachments. This is a prospective multi-center study where they found out that emergency physicians, not all of them were fellowship trained, this was like all comers, had 96, almost 97% sensitivity for retinal detachments. Our sensitivity was a little bit lower at 88%, but the ophthalmologist worries about my specificity. I worry about my sensitivity, so I'm okay with these numbers. However, if you want to get those like couple of extra percentage points, things that you can do are get a better exam of the eyeball, because not all retinal detachments are super easy to see when you first put that probe on. If you just tilt the probe up and down, you'll really only see the posterior 1/3, maybe 1/2 of the eye. But if you really slide that probe as well as tilting it, you'll be able to find these more anterior edges of rips and tears that are going to be a bigger problem for the patient as they grow, and ophthalmology can make a bigger difference by repairing them sooner rather than later. So here's a patient with a small tear right on the edge of the periphery of their vision. This isn't causing them any issues with their central vision, and they basically just came in because they had flashes. The next myth that drives me crazy, mostly because point-of-care ultrasound people, like specialists themselves, talk about it, is that they say you can differentiate a vitreal detachment from a retinal detachment because a retinal detachment will not cross the optic nerve. Which is true, the retina cannot cross the optic nerve. Here's an example of a retina that's detached all the way down to the optic nerve sheath. It can't cross the optic nerve because it goes to the optic nerve. That's where this tissue is from. It can't split off of it. But I don't want you to wait until retina tear is bad enough to call the specialist and to send this patient to the right spot just because you've heard this myth. This is an example of a patient where that was clinically relevant. This is a 56-year-old man who came in because he'd had some blurred vision in his lower field while he was watching TV the night before. He just thought it was kind of fuzzy. The next morning when he woke up and it was still there, he came into the emergency department first thing in the morning and was evaluated with his point-of-care ultrasound, and he's found to have this little tiny tear right at the edge of his vision. Ophthalmology had him in the OR within several hours because he was NPO, because he came in right away. So this little tear is nowhere near the optic nerve, and if we had waited until it got to this tear up here, he would have lost basically all of his vision in that side of his eye, when instead he lost basically none of his central vision because his hair is up here in the periphery, kind of up here, and then when you move his eye, this is his optic nerve right here. So his tear's up here, and his optic nerve is way down here. We didn't wait for it to get that bad. Here's his little tear right here, now that he's moved his eye back, so he's moving back and forth. The other thing that can sometimes be helpful is when do we call our consultants? Here, we call our consultants all the time, so you get a very poor sense of when it's an emergency to call the ophthalmologist and when it's not, because our ophthalmologists are always in-house, they're always interested in seeing lots of cases, and so we don't get a lot of pushback when we say, hey, can you come see this patient? But when you're in the community, the ophthalmologist doesn't want to come in unless they really have to, and so it's helpful to know when you should call them and when you can't, or when you shouldn't. Most patients can be evaluated and then referred to ophthalmology at the next business day or in the morning. A lot of ophthalmology clinics will get you in right away if you call in the morning and say, hey, I had flashes and floaters. They'll get you in that day somehow. And these are kind of these small fires that just have to be watched and referred to the right spot. But there are 2 situations which are kind of like 4-alarm fires. One of them is a patient who has a MAC-on retinal tear that you're worried about, or superior retinal tears, which need maybe a call in the middle of the night, if not pretty urgent follow-up the next morning. So superior tears are a special case of tear where the tear gets worse much faster than it would if it was in the inferior portion of the eye, because a little tiny tear up here allows fluid, and then the fluid in the back of the retina will then pull down because of gravity and make that tear much worse faster. There's a special view for it. Usually when patients are closing their eyes, they look down. So most of the view that we see of the eye is inferior. But if you take off that film, if you have some on, and you look at the inferior eyelid instead with them open eyes looking up, like this tech that I have here who's being helpful for me, you'll actually see a very good view of the superior orbit. So if you're really worried about a patient, you don't see anything in the rest of their exam, it's probably worthwhile looking at the superior orbit for retinal detachment. The next special view to look for is this visual axis view, which is how we identify where the macula is. So the macula on a fundoscopic exam is this nice big bright white red spot, which really shows up well next to the optic disc. But on ultrasound, it's sonographically indistinct from everything else. It just looks like everything in the rest of the retina. So if you manage to get the lens in the front of your view and the optic nerve in the back of your view, what this lens is doing is it's focusing the light on the macula just temporal to the optic nerve. So if you can manage to get this visual axis view where you have lens and optic nerve, the macula is always going to be right here on the temporal side of this. In order to do this, have the patient look forward with their eyes closed and then try to find this view. If you care, for some reason clinically, you need to know which side of this optic nerve is the macula. I usually remember it by the mnemonic of that the optic nerve is coming from the optic chiasm, and so it's coming from the nasal side, and so the macula is going to be temporal to that. This is a patient who had a tiny tear, but it was sadly actually involving the macula right away. So here's his little retinal tear. He had lost inferior vision in the lower portion of his central vision already. So even though it's a tiny tear, this patient was fairly emergent and was taken to the operating room quickly because he has this tiny tear, which is directly affecting his macula. And if he loses any more of it, he will probably not be able to read with this eye. Next, retinal detachment mistruth to talk about is a lot of people will say that if patients have a vitreal detachment, then they don't need follow-up because you've identified the cause of their flashes and the floaters. The problem with this is that this vitreal detachment, and I've overgained this over here so you can see this vitreal detachment kind of swinging around in here. As you might guess, this is causing a little bit of traction on the back of this retina. And right here on this non-overgained image, I'm about to play in a second, but there's a little bit of retina that's already been torn up here in this patient. So this patient needs follow-up, maybe not today, but probably tomorrow with ophthalmology in order to evaluate this a little bit further. I will send all patients with symptomatic retinal detachments to ophthalmology the next business day. So if it's a Friday night, I'll send them to ophthalmology on Monday. In order to evaluate their eyes for possible retinal tears that I miss on my ultrasound. The last myth that I like to talk about is this black curtain thing that we get tested for on board exams, but I've never had a patient tell me that they have a black curtain vision loss. This is a patient who had purple smoke that they complained about. He said he had this like little area of purple smoke right next to his nose in his visual field, and that was this retinal detachment on the side. And then this is another patient who said that she had this green angled line on the inferior lateral portion of her view that just kind of stayed there for a couple days. So she came in, and this is her retinal detachment right here. So now that I've gotten through my soapbox, we'll talk about a couple other artifacts that can be helpful for you and then gain an extra views. So lenses can cause a fair amount of artifact for you. So if you see like this little line back here, this is actually just a reflection of the sound from this lens up here. Patients who have cataracts in their native lens have a lot of artifact off of it. So this is a lot of reverberation artifact, this curvilinear curve here. It's so bright that it's almost erasing this posterior vitreal detachment that this patient has as well. There's sort of an irregular line back here. The good news is that this is a really easy artifact to fix. You just have the patient look away from the probe. So you have them look in the opposite direction of where you're scanning, and then usually that gets that lens out of your way so that you can then see the back of the eye without too many problems. The next thing that I want you to be aware of is that your gain is significantly affecting what you're seeing in the eye. If you have too much gain, you'll wash out any posterior findings in the eyeball. And if you don't have enough gain, you'll miss posterior chamber findings of the eyeball. So depending on what you're looking for, you may want to turn down the gain. I would say you definitely want to turn up the gain if you're looking for any visual defects that patient has, as you may find things in the eye that don't otherwise show up. Here's an example of one of those such findings. So here's a retinal detachment. Retinas are usually fairly easy to see with normal gain. So this is a nice bright retina. Like I said at the beginning of this talk, the retina is very bright and echogenic, so it's pretty simple to see. But you might miss the fact that this patient here, their visual deficit is secondary to their vitreal detachment, which only shows up when we really turn up the gain on the machine, which we see on this right-hand video right here. So some pathology-specific views. We already talked about the superior orbit view for retinal detachments and the visual axis view to look at the macula. Kinetic motion can be helpful for you. So the specific views that we ask about for QPath for extra credit is usually, or so for your credit, is kinetic motion, trauma. We can be looking at some extra views, and then optic nerves. So if you have somebody with a vitreal hemorrhage, the kinetic motion, which is when you ask the patient to bounce, to kind of look their eye both to lateral and then medial and then back again and then hold still, will often mix up some of this hemorrhage so you can see if there's any areas where it's actually attached to the back of the eye or if there's a retinal detachment that's hiding in here. So this patient has this vitreal hemorrhage. When we have him move his eye around, it actually looks pretty good. And we have good movement of all this hemorrhage material in the eye, so we worry less about there being a retinal detachment in there. Here's a patient with a retinal detachment. Here on the right is a patient with just a vitreal hemorrhage. And you can see that the retinal detachment actually moves differently with that kinetic motion. It sort of looks like it's tethered down on one side and looks almost like a rope that somebody is whipping as the patient moves their eye, versus this vitreal hemorrhage moves around like a big washing machine full of clothes. It's kind of going around in circles when they move their eye. So that's how kinetic motion can help us. If you're looking for traumatic findings, it helps to turn the gain up and down depending on what you're looking for. This is actually a normal eyeball, but I wanted to show it to you because it's really good views of this posterior orbit. So in the posterior orbit, you guys are used to looking for the optic nerve, but the other things you'll sometimes see are the extraocular muscles. So here's the lateral rectus and here's the medial rectus. And right here at the very end of this, as we get through the optic nerve, we get the superior rectus right here. So those are normal findings, but if you see a big, huge blob back here, which has similar like kind of hypoechogenicity, that might be a hematoma. You want to increase the gain if you're looking for things within the eye itself. So for example, this is a patient who had blunt trauma to their head. The trauma was not at their eye, so we weren't particularly worried about a globe rupture, but they had a significant change in their vision. And it turns out that they have this finding, which is usually only visible if you really turn up the gain a lot, and that is that they have a displaced lens. So this is their lens right here. It is sort of hanging by a thread from the iris right up here. They've got a little bit of blood associated with it. These are very challenging to find and usually do require a lot of gain to be able to find them in the back of the eyeballs when you do look for them. Here's another patient who had similar story, blunt trauma to the head, sudden change in their vision, which seemed like their lens was dislocated. But they didn't actually have a lens dislocation. They have this linear foreign body back here, which is actually an implanted contact lens, which I didn't even know existed until I saw this case. So this patient had displaced their implanted lens to the back of their eyeball with the trauma. This is a patient who was in an ATV accident and has a very large hematoma in this kind of periorbital space. This is not a retrobulbar hematoma because it's anterior to the lateral canthus, but it is what a hematoma might look like if you might see one in this posterior kind of fatty area around the orbit. So something to look for if you are worried about somebody's vision after blunt trauma. Last and not least, we're going to talk briefly about the optic nerve sheath. So you guys are already familiar with measuring the optic nerve sheath. We measure it 0.3 centimeters behind the eyeball itself because that's where MRI studies have shown us the optic nerve is the most stretchable. So if somebody has increased ICP, this optic nerve sheath at this space is usually 6 millimeters or larger. Just one thing to be aware of is if you get this at a kind of an off-axis angle, it might be a little bit enlarged just because of that. So some books will say 5 millimeters or larger is increased optic nerve sheath diameter, but I find enough measuring artifact issues at that size that I usually go with 6 millimeters. You might also see some papilledema. This is a patient who doesn't have papilledema, but does have sort of a generous looking optic nerve sheath. They were in status epilepticus for a couple of hours prior to this. So there was some concern for increased intracranial pressure. This is a patient with papilledema, thanks to Dr. Duan, who recorded this image of a patient with intracranial hypertension. You can see that their optic nerve, their disc is sort of poking into their eyeball right here. So this is fairly effective for papilledema, probably better than my exam for papilledema, since I don't dilate eyeballs and I'm kind of crappy with my fundoscopic exam. This is a patient, actually, no, this isn't a patient. This is a friend of mine from residency who has drusen at the back of his eye. So just as a fake out for papilledema, just make sure that you don't call people's drusen, it's like kind of hyperechoic area right around the optic disc, as an abnormal finding, because it is not. People who have monocular vision loss in one eye, you always want to worry about a possible eyeball stroke, also known as central retinal artery occlusion. So this is my eye with a little Doppler signal back here. If you're missing this Doppler signal and you don't see a little bright dot back here, this patient might be a very good candidate for TPA. This little echogenic dot right here probably means that they have an atherosclerotic embolism, which usually is not particularly treatable with TPA. Here's another example of the same thing. There's several case reports out there, point-of-care ultrasound, showing these little kind of hyperechoic spots at the back of the eye in these patients with fairly profound, although not complete, vision loss. Usually what you lose is all of your central vision and have some like kind of light perception available because of some collateral vessels. If a patient does not have that little spot sign and you're less than 4.5 hours, then about 50% of patients in this study ended up with return of their vision, or fairly significant return of their vision, with TPA. So if no spot, and if you are concerned about central retinal artery occlusion, it's worth considering TPA. Here, you would be considering calling your consultants prior to that point in time, but this might help you out in the community when you're having to make this decision on your own. Other things that we're taught about in our board exam are things like ocular massage, decreasing the ocular pressure with acetazolamide, really haven't been shown to be very effective for this finding. So in summary, flashes, floaters, and visual field cuts should prompt you to go ahead and grab your ultrasound and take a look at these patients. Try and identify the optic nerve and scan through as much of the periphery as you can, particularly the superior orbit. You want to make sure that you're adjusting the depth and the gain while you're doing that scan for better sensitivity and specificity. And also don't forget your kinetic motion as one of your possible special views in order to better differentiate retinal detachments, vitreal hemorrhages, and things like that. Interestingly, there's lots of pathology in the eye that we never learned about in medical school. So if you do find something that's weird, go ahead and grab a couple clips of it, and then feel free to call your ophthalmologist, who is your consultant. A lot of them do ultrasound, and I actually have described findings on the phone, and they have given me the identification of the diagnosis when I've done so. So they're pretty good.